Welcome everyone to the April 2021 Levitt lecture that I'm most proud to present. For those of you who don't know, Louis Levitt was born at the end of the 19th century. He was born in 1897 in Denver, and he went to medical school in Denver, graduated from the medical school here in 1927, and practiced for 40 years as a general practitioner in the city of Denver until 1967. Upon his death in 1976, we learned that he had bequeathed to the Department of Family Medicine an endowment to bring distinguished speakers to the campus through the agency of the Department of Family Medicine to educate us, inspire us, edify us, teach us things that we ought to know. And since that time, I believe we've used his endowment to good effect. We have had almost 100 Levitt lectureships. The one that you're going to hear today is one that I'm particularly proud of. I'll introduce our speaker in a moment, but let me just give you a heads up first that the talk that you're going to hear today is going to be one of a series of Levitt lectures that build on each other and develop the notion of how to reimagine leadership in rural Colorado and rural US, and essentially rethink rural healthcare. I'm very pleased to introduce to you our speaker for this Levitt, Ben Anderson. Benjamin Anderson has been one of the happy accidents of my last year of being here. I had no reason to expect Benjamin Anderson to fall out of heaven and for us to enjoy the benefit of his presence. Ben is going to talk with us today about a path forward, thriving in rural healthcare after COVID-19. He's very well equipped to do that. Ben is the vice president at the Colorado Hospital Association. He works there for health and hospitals in rural health. He provides leadership and direction for the development of their rural strategies, the Colorado Hospital Association's rural strategic plans. And he struck up an unbelievably potent and almost scary partnership with Lauren Hughes, who is an associate professor in our department, who works as the state policy director for our state after working for a time in rural health in the state of Pennsylvania. The two of them developed a playbook, which is called Reimagining Leadership, Pathway to Rural Health to Thrive in a COVID-19 World. And that playbook, not only did it get distributed throughout the state to rural hospitals and rural communities, but it also got distributed nationwide. It's been a smashing success, and its life is not over. There continue to be interesting follow-up activities around that promise to help us deal with the scary, thin, fragile state of affairs for rural health in Colorado. So I'm very proud to have you here, Ben. Before I turn the mic over to you, I would like for Lauren to take a few moments to speak with us about whatever you want, Lauren. You're as much a part of this as Ben is. So I'm going to go on mute. Lauren, take yourself off mute, and let's see if you can roll up into a Levitt lecture.
Wonderful. Thank you so much, Frank. And apologize to everyone for speaking to you with my video off. I'm having unstable internet here at home and would rather not freeze while I'm sharing a few thoughts with you today. So I'm very excited that all of you will have the pleasure of hearing from my friend and colleague, Ben Anderson. We had the pleasure of meeting just a little bit over a year ago when I attended the Rural Health and Hospitals Conference in early March. And during that conference, that very Friday was when the governor called or put a call together, and all the hospital execs were there to talk about this thing on the horizon called COVID-19, and what a time it has been in the 14 months since then. Ben and I quickly discovered that we have shared interests and philosophies when it comes to strengthening rural healthcare delivery systems. Those mutual interests grew into an incredible opportunity to partner on the development of the playbook that Frank mentioned, and Ben will speak more about during his talk today. Ben and I had the opportunity to serve as co-principal investigators on the playbook, and in essence, it provides a series of resources and tools to help rural healthcare leaders identify and solve a wide range of problems related to COVID-19. A couple other points I'd like to make about this work. The first is that it has led to some pretty exciting follow-on opportunities. I think this is important, especially for a policy relevant initiative like this, not just to make a one-time splash, but how can we build upon the work of this playbook as a foundation for future work. Certainly, the debut of the playbook has led to several opportunities for Ben and I and other colleagues to present on this work. We are now kicking off an implementation study and have secured funding to help implement the application of this playbook for primary care practices in rural areas around Colorado, as well as rural hospitals. Next week, the playbook will be used for a hackathon event that the Colorado School of Mines approached us after it came out and said, would you be willing to have this playbook be used for our engineering students to develop hacks or to solve problems related to what we spoke about in the playbook? And we said, absolutely. So that's a fun event. It's also led to the development of rural case studies to help build leadership capacity among rural health leaders. And I will defer to Ben to speak about that a little bit more. And the last thing I want to say before I turn it over to Ben is the opportunity to work on this playbook, I think, illustrates the value of three key things. One, pursuing practical work that builds upon each other. If you haven't had a chance to, but will at some point in the future dig into the playbook, you will see that this is not an academic publication, but rather a very practical tool to be used in the field. The second is the importance of engaging in policy relevant research that has impact. And certainly from Ben's and my perspective, the rural health space certainly needs a great deal of attention and support. And last is from the two of us working together on this and several other follow-on projects, there's been the opportunity to develop a strong partnership between the Farley Health Policy Center and the Hospital Association, partners that may not have known about each other before or worked together in the past, and excited for what the partnership will lead to in the future. So with that, I will turn it over to Ben, and thank you all for coming. You are in for a treat today.
Well, thank you, Dr. Hughes. Thank you to Frank for the wonderful introduction. Slightly uncomfortable for me, but I'll be glad to be with you. I will acknowledge publicly that I'm wearing a tie. Perhaps for the first time in a year. I was a scrappy rural hospital CEO for 10 years, and I was told pretty quickly when I showed up there that I look like somebody from New York if I wore a tie. So I'm out of the habit of wearing one, but I'm under the impression that there are some pretty fancy folks on this call. So I'm wearing a tie for you. So I'm going to begin by sharing my slides, and we're going to jump into this presentation. Frank, if you just want to confirm you can see my slides, it'd be great. We're good? Okay. So I'm a storyteller by nature. I'm going to start by telling you a story. And I just want to begin by saying it's a pleasure to be with you. It's an honor to be included in this long series and this really history of education and academic excellence going on at the University of Colorado School of Medicine. First story. This is a picture of my two kids, or two of my four kids. We've got two 8-year-olds at our house, and we have two 6-year-olds, and they're boy-girl sets. And so the girls in both sets are right here. Their names are Maria on the left, Naomi on the right, and they have created a carriage using some blankets and some string. It's a horse and buggy, essentially. And the horse is Stinky Pinky the pig, and he is pulling them around the front room. And so what's behind this is this was day 10 out of 14 days that we were isolated in our home in March of 2020 at the outset of COVID-19, while I was working 18-hour days to try to find coveted N95 masks for our rural hospitals who are at the end of the supply chain, because nothing in March of 2020 said, "I love you," like an N95 did. So we were working on that for 18 hours a day. And meanwhile, our kids could not leave our small home at the corner of Quebec and 12th. Because we didn't know what was out there, and we were trying to isolate enough to be able to figure out if we could get somewhere else besides this little home. And so our kids were climbing the walls. We were seeing behaviors. I mean, you all, many of you with small children can relate to this, or have small children in your lives to relate to it. But we recognize that this, for the coming 6 months or even a year, would not be sustainable. And what we needed was to spread out a little bit. So fortunately, I married somebody who's from a small Kansas farm north of Topeka, a little town called Sabetha. And this is a picture out their front door of their house. And we knew that grandparents and grandmother were isolating just like we were. And if we could figure out how to get to their house without even so much as touching a gas station handle, without a glove, and without stopping for a bathroom, maybe even side of the road, and I won't even go to those details, we could get here and we could spread out, and the kids could touch anything they wanted to. And so that's what we did. So in late March 2020, or mid to late March 2020, we showed up here, and something remarkable happened. As I was working these 18-hour days from a guest bedroom in Kayla's parents' house, I looked out the window and I saw my kids experiencing rural life. I grew up on the West Coast in the Bay Area, California, and I did not grow up in rural America. I spent 10 years there as a rural hospital CEO, and would say that there's a piece of me that will always remain there. But it's different than growing up there. And so I got to witness my wife's precious, sacred childhood through the eyes of my daughters, through the eyes of my four kids as they were doing this. So this is Naomi on a zip line that had been put together by her papa. This is Maria climbing on a cattle guard. This is Naomi down at what they'd call the creek, or a little stream that goes into a pond that's on their property. This is them climbing on fences and swinging on a tree swing, being pushed by Kayla's father, playing out in the garden. And through that, I got to imagine what Kayla's childhood must have looked like. I could only hear stories about it from her growing up in rural America and how much she loved and cherished it. But it was hard for me to imagine until I saw this through the experiences of our girls. And so I imagined her being a young girl out on that same piece of property, interacting with the animals, playing in the wide open spaces. And I saw them running through the trees, our daughters running through the trees in the windbreak that was nearly 100 years old at their house, that protected their house from the Kansas wind. And I imagined how it must have been growing up at dinner tables and devotions in the evenings, and just the chores and the regular routine of daily life there that she loved so much. And through that, I was able to imagine what it would have been like for her mom growing up on that same little area of Northeast Kansas, and for her mom's mom growing up on a little chicken farm in that same area. And as I was watching my daughters run through the trees, through the windbreak, the words, "Oh, beautiful for spacious skies, for amber waves of grain, for purple mountain majesties above the fruited plain. America, America, God shed his grace on thee, and crowned thy good with brotherhood from sea to shining sea." And it hit me as I was thinking of those lyrics, which it was a poem written by Elizabeth Ann Bates in 1895 that later became the famous patriotic song, "America the Beautiful." Those words were written by her after she toured rural America on a train. And it hit me as I was thinking about that. This is what we're fighting for right now. We have 60 million rural Americans that are hoping their children experience at least as good of a life that they have growing up in these areas. And as we fight for funding from the federal government, as we fight for PPE and for staffing and to solve problems and build systems and design transfer centers or transfer protocols to ensure that nobody dies that doesn't have to, this was really what we were fighting for. So that said, I also want to acknowledge in this story and in this presentation that there is a shadow to rural America too. And that shadow includes, like any community, any culture has a shadow. That shadow includes some racism. It includes some discrimination. It includes some fatalism. It includes opiate problems. It includes chronic public health issues that have placed or landed rural America as the caboose on the health outcome train in the United States. There are some systemic and cultural issues that are driving that do not, from my perspective, overshadow the beauty in rural America too. But we've got some work to do, and I want to talk a little bit about that after I share one additional story. This is the story of David. And David is our older son. David loves to learn. We write book reports and read books and write book reports, and he sends them around the country to friends and family who send him back a grade on his book report with $1 for his efforts, and he gets to learn how to save and give and spend with those dollars, and then he takes the response, the card from whoever. This one happens to be from his Nana, and he goes and looks at geography and figures out where that came from, and he's able to put his color of a sticker on a map. This is something he loves to do in our home and part of our family. But David loves to learn. He loves to build. He loves to take things that don't go together and make them go together to create something that's never been created before. He loves to play. This is outside near our home. This is outside in the snow. He loves sports. Like any little boy, he likes anything with a ball. He loves to be outside, and particularly on a bicycle or on a hike, and we do that every Saturday. He loves the mud, much to his mother's chagrin. He loves to work and will work for ice cream, and wants to be a police officer, as he frequently says, but he also wants to be a farmer like his papa. He loves to grow things and be outside and be in the dirt. He's funny. He has a soft, humble, teachable heart. He loves his siblings, and he loves his mommy. And he loves a particular story, and the story is the story of David and Goliath. And of course, we all know the story of the underdog, David, and his defeating Goliath. And I'm not sure exactly why it connects with him. It could be because his name is David and he identifies with the character. It could be because it's, about war or fighting or battle or things like that. But I think, as I've reflected on it, I think the reason why this story means so much to him is because it's a story of an undersized kid, not much older than him, that shows up with a handful of rocks at a sword fight. And he wins. And he wins. And so each night I get into his room and I sing him a song, and the lyrics are only a boy named David, only a little sling, only a boy named David. And he loves to play and sing, only a boy named David, only a bubbling brook, only a boy named David, and 5 little stones he took. And 1 little stone went into the sling, and the sling went around and around, and that little stone went high in the air, and the giant came tumbling down. Each time I sing him that story, he replays it for me. Step by step, play by play, as though I've never heard it before. He tells me the story again. And one night, he went on to ask me a profound question. He said, "Dad, did I beat Goliath?" And what I wanted to hear his heart in this. And what I deciphered after some clarification was, what he was really asking was, "Dad, could I beat Goliath? Could I beat Goliath?" And David would meet his Goliath. A few years ago, he would be diagnosed with a rare form of epilepsy that would lead to 60 seizures a day that would affect his behavior, his short-term memory, or ability to learn, the way that he interacts with other kids and adults, and the way he functions on a day-to-day basis. We would discover this through an angel flight. There were some pilots that volunteered to take us from the 10th most remote town in the United States, which was where we were living in rural Kansas, all the way to the Mayo Clinic, which was a 4-hour commute on a little Chrysler Mini with wings. It's how long it took us to get there, but we would end up there, and we would end up with a solid diagnosis and a medication plan that would curb his seizures, but that would not address the other issues related to his behavior and his learning. So behavioral health hits home for me in a very real way. So we ended up, after 2 years of exhausting every resource we could find, leaving our precious rural community where we'd served in that region for 10 years, to move to Colorado to access the Denver Academy, which is, if you aren't aware, is an amazing organization. And he is thriving. And 2 months ago, he was Student of the Month. We got this note with the certificate and just nearly fell over. But I'm sobered and reminded that there were things that were determining the outcome of this little boy that I couldn't control as his dad, even as his father, who was a hospital CEO that served 20 counties in Southwest Kansas. I couldn't fix this stuff. And so I have a mentor, a close mentor of mine, who I've known for over a decade, for 11 years, whose name is Sister Mary Jean Ryan, and she was president and CEO, and then later board chair of SSM Healthcare. And she was the CEO of SSM when they were the first ever organization to win the National Malcolm Baldrige Award for Quality. Healthcare had never been in Baldrige, but she was a relentless advocate for quality and was so determined. And so when I read a New York Times story about her retiring and being the last in an era of nuns that were running health systems, I just cold called her and said, "My name's Benjamin and I'm in a tiny hospital and I don't know what I'm doing. Will you take phone calls from me from time to time?" And that was 11 years ago. And we've developed a really close friendship. And she taught me something that I'll relay to you, and that's that systems heal people and systems harm or kill people. And the development of good systems requires good strategy. This stuff doesn't happen on accident. It doesn't happen on accident. We're going to talk a lot more about systems today, but first let's look at some disparities that maybe are a reflection of the shadow that's going on in rural America. This is a map on Rural Health Information Hub that's an HRSA source, actually, from the Health Resource Services Administration, that shows primary care shortage. In the darker the green color, the more acute the shortage is in a rural area. And the darker the blue color, the more acutely the shortage is in an urban area. And you look at the map and you look at rural America, and we realize we have a problem in rural America with primary care access, and that problem is undeniable. It is a very serious issue. Let's look more at an individual level, look at people. When you look at American workers in poverty, a much higher percentage per capita of American workers in poverty are living in rural America versus in urban America. When we look at infant mortality rates, your risk of dying or harm is higher if you're in a rural area, and highest if you are a person of color in rural America. So even risks, even stratified by race, the data does not look good for rural America when we compare with our urban counterparts. When you look at the timing of death due to unintended injury, access to an emergency department and the capacity within that emergency department definitely determines life expectancy. And in fact, rural Americans are 50% more likely to die due to unintended injury than urban Americans in the United States. So, are these issues stemming from choice? Or are they more systemic? Are rural Americans, and I ask this, I'm in front of audiences across the country, mainly rural ones. A common question I ask is, are we dumber in rural America? Are we just less sophisticated? Or do we care less about our health than our urban counterparts? Are we less responsible? Or are there more systemic factors that are determining these unfortunate disparities. Think about this. This is a pyramid that we frequently use when I was a CEO, and it's an outcomes pyramid, and it looks at the root causes of health outcomes or the root causes of death, and at the top of the pyramid are outcomes. And for the purpose of this discussion, let's think about COVID-19. Could be COVID deaths, COVID hospitalizations, COVID infection rates, those types of things. Those could be health outcomes. The factors that lead to the health outcomes are the human behaviors. That's in the middle of the pyramid, and you can use your imagination to determine, what are some of the factors that are even currently contributing to COVID outcomes. And it might be vaccination rates, or it might be, or the decision to get vaccinated, or the decision to wear a mask, or to socially distance, or to sanitize your hands, or whatever those things are. Those decisions that lead to health outcomes are in the middle, but at the bottom of the pyramid are the factors, the human condition, the factors that lead to the decisions that lead to health outcomes. And I want you to take this and freeze it and imagine to the right of it would be a pyramid with education outcomes, and we have graduation rates of kids, or we have college admission rates, or we have teen pregnancy rates, or whatever those outcomes are with the education pyramid. You might make slightly different decisions to lead to those outcomes, but at the bottom of the pyramid are the factors, the human condition that leads to the outcomes. Then think about another pyramid to the left with law enforcement and its incarceration rates, or arrests, or whatever their outcomes would be. Then there are decisions, and then there are factors. The factors in each of these pyramids are almost always the same. So if we are going to address these disparities, we have to look at them at a systemic and structural level. At the bottom of the pyramid, we all had to agree. And when I was the CEO, we would get together once a year with the school board, hospital board, the sheriff's department, the community leadership. We'd get folks together and we'd ask the schools, what kind of shape are our kids in? Do their teeth hurt? Are they hungry? Are they struggling to focus? You think they're experiencing abuse? What's going on with them that would be a barrier to their learning? Because those things are also probably barriers to their health. Let's all agree on one thing that we can work on together this year. You can't solve structural problems with individual solutions. And we try it over and over again. We're trying it right now with burnout. We're saying to our tired healthcare workers, if you just take a vacation, it'll all be better. Try this mindfulness class. Try this breathing exercise. Just take a nap. Go take an afternoon and walk in the mountains. You'll feel so much better. Essentially, we are saying all the structural issues that are driving your burnout, those things really aren't the focus. The focus is that you just need to be more mindful. And when we think about this stuff, we can't solve structure. Yes, there's a responsibility of individuals to make decisions that lead to better outcomes, but we must also solve the structural issues too. I'll add to that COVID-19 has revealed fault lines in rural health that were already there. It just went from hairline fractures that we couldn't see to compound fractures that are so obvious we can't ignore them anymore. These things exist. They're among us. They're impossible to ignore. And in the words of our former president, George W. Bush, let's remember, he released this statement just at the outset of COVID through the Bush Center. Let's remember that the suffering we experience as a nation does not fall evenly. In the days to come, we will be especially important to care in practical ways for the elderly, the ill, and the unemployed. Let's say this: tolerating any disparity risks the legitimization of all disparities. This is expensive for all of us. We can't say one disparity is okay or not worth focusing on, and another one is not. Because if we ignore some disparities, we legitimize the others. And we have to be able to look at disparities objectively and say, how can we live in a nation where we do hold these truths to be self-evident, that all people are created equal, and that they're endowed by their creator with certain inalienable rights, and among these are life and liberty and the pursuit of happiness. I'm going to give you a fun story on how we are addressing disparities through the Colorado Hospital Association. So there is a structural difference in the supply line for rural hospitals and urban hospitals, for rural clinics and urban clinics, for rural public health departments and urban public health departments, because we don't have the buying power in rural America to buy 200,000 N95s. We just need 200. We just need a few. but those few that we really needed. And so we were finding that we were seeing staff in some rural hospitals showing up in fishing bibs for PPE, doctors showing up in fishing bibs for PPE at the outside. We were hearing stories of rural hospitals across the country that were having staff showing up in trash bags. Like we only want the best for our staff. It's glad or hefty, right? This was going on in the United States, and that wasn't okay to us, but we had to think through, well, how do we solve this? How do we hack it together? And so an effort called #Heart4Heroes was launched with a business owner, an online business owner out of Nevada. He contacted us and said, how can I help? And we partnered with Project Cure, which is an international nonprofit organization based in Denver that collects equipment and supplies and sends them to underserved areas. They switched their focus from global to the US immediately at COVID and started shipping things out to rural hospitals across the country or trying to, and we connected them with Angel Flight, which is a group of several thousand pilots to donate their planes and their gas and their time to get PPE out. And so within hours, we could identify a need, we could source that PPE that was so desperately needed, put those boxes on an airplane that could no longer take patients to appointments. So they just switched their focus to taking boxes out to hospitals. And in the nearest landing strip near a rural hospital, say in Gunnison, Colorado, they would land and they would drop off the PPE just in the nick of time. And I remember that CEO in Gunnison, for example, seeing one of those planes land with exactly what our staff needed it was like out of a movie. It was like angels touching down and giving us exactly what we needed. And these are all the sites over the course of the following 6 months that received free PPE through this effort. And it wasn't just hospitals. It was all safety net clinics. It was nursing homes. It was public health departments. It was frontline workers or EMS or emergency responders. They were receiving PPE through these efforts, and over 500,000 pieces of PPE were delivered in the subsequent months because we got together and decided to solve a problem together. This is a system solution for a systemic problem. So addressing disparities, to use that example, requires careful strategy. We have to be intentional about this stuff. And I have another close friend or mentor that's now at the Dell Medical School. She founded the Value Institute for Health and Care with the University of Texas at Dell Medical School and also the McCombs School of Business. They partnered for this Value Institute. And she started it 3 years ago, and they now have a really cool online master's program called the Master of Science in Healthcare Transformation program. It's a 1-year, a mid-careerist, mostly online, a few trips to campus, but meant for high-performing leaders that want to transform systems. She's like a grandparent to our kids. And she taught me another lesson that really is that strategy requires reverse thinking. She's an engineer by background from Stanford. And she wrote about this in her book, Redefining Healthcare, with Michael Porter from Harvard, with Porter's 5 Forces. And they wrote this book in 2005 on redesigning healthcare. But she said, what she learned through this is that strategy starts with the end in mind. Think about where we want to get and ask, well, what has to happen for that to happen? And what has to happen for that to happen? Continue to go backward until we get to where we are. And then we've got a roadmap moving forward. So that's exactly what we did at the Colorado Hospital Association. So we started like this with a driver diagram, started backwards. Achieving optimal health for rural Coloradans requires monitoring outcomes of deliberate and tactical interventions fueled by training and partnerships to achieve SMART goals, specific, measurable, attainable, relevant, and time-sensitive goals, based on careful assessments of reliable information. That was the driver diagram that we launched, and we rolled this out at the Rural Conference in Golden, Colorado on the same day that I met Dr. Lauren Hughes, and on the same day that COVID touched down in Colorado. We had no idea when we were developing this strategy that it would be in the face of a historic global pandemic. And so this is how it really played out in a one-pager. So the vision is value-driven systems, increase capacity, and innovative payment structures that optimize health and strengthen rural communities. That's the North Star, essentially. It shouldn't matter what zip code in Colorado you live, you should be able to live just as long. You should be able to live just as actively. You should be able to live a fulfilling life, no matter where you are. We want to close those gaps by increasing capacity. So the four focus areas are leverage data to inform system development and interventions, increase leadership and workforce capacity, improve access to excellent and holistic care, and strengthen partnerships and collaboration. the Colorado Hospital Association had a lot of work to do around partnering with its neighbors and developing a collaborative culture within the state, and the entire leadership team was committed to seeing that growth happen. So this was really it. These were some early, just in the last 12 months, some early partners that volunteered to join us in this effort. And some of them are funders. Some of those funders are on this call: Caring for Colorado Foundation, or Zoma Lab, or Zoma Foundation. The Colorado Health Foundation has been huge. Gates Family Foundation, Rose. Each of these partners have been huge in helping us advance this and even accelerate its impact. And then here are some other ones that are on this call who have expressed interest or are actively, in fact, all of them are actively partnering with us. Some of them are academic institutions, and even some for-profit partners as well. So we've seen the strategy, its implementation, accelerate and not decelerate during COVID. But essentially, this strategy is about 80% capacity building and 20% about policy. Traditionally, the Colorado Hospital Association has been a very effective advocacy or policy organization. But what Chris Tholen, our president, really in his brilliance recognized is that we want systems that can make the optimal use of good policy. So let's build capacity within our healthcare delivery systems collaboratively with other safety net or other care delivery organizations. But the primary rural strategic focus is on capacity building around leadership and governance. We're going to talk more about that. Pause again for another wonderful quote on addressing these disparities. This is Michelle Obama. We just don't have a roadmap for what we're currently experiencing. That in and of itself can bring up feelings of anxiety, loneliness, and fear, not to mention the worry we feel about the health and safety of our parents, our children, our loved ones, the financial security of so many families. This was said nearly a year ago. It's still true, even more true today. We're still trying to navigate this as we grapple with what we're dealing with as a nation. So, as Frank mentioned earlier in the introduction, we did work about 6 or 7 months. Lauren and I labored over this with 7 other authors and many other folks helping advise and research. We put together a 134-page playbook that is essentially life after COVID. And it says rural in the title. This stuff doesn't only apply to rural. And it was in some of the final interviews. And in fact, I think Dr. Hughes was in an interview with a pair of CEOs, just one by one, on a particular day in the final days of our interviews, where one of them held up Patrick Lencioni's 5 Dysfunctions of a Team. It was a leadership parable. Held up that book and said, if you want this to be helpful, it's not going to be because there's a website with a bunch of links for PPE that'll be outdated in 2 weeks. Make this a tool that can help us build the capacities within our leadership teams to solve our own problems in our own context. Make this case-based learning. And then include in there some strategic questions that we can ask our own teams that will help us build our own capacities across the country. And so we wrote and it included 2 very realistic cases. They're fictitious cases, but built around true stories. So there's juicy stuff in them. There's the staff member who goes rogue and goes to a local radio station and accuses her employer of falsely reporting COVID-19 positive stuff. There's the Texan that shows up in fishnet pantyhose as a tourist with those fishnet pantyhose over his face as his mask, saying, "Dadgummit, I'm not going to wear masks." There are people with makeshift PPE. All of these things were happening. All these things were happening in our rural healthcare delivery systems as we interviewed either clinics or hospitals or public health departments and others. These were the true stories as they poured out their hearts to us when we went and visited them in the middle of this crisis. So we wrote these cases in, encouraging the reader of this playbook to draw their teams into these cases and to solve their own problems. So I want to pause as I describe now this playbook with the 9 challenge areas that folks can really dive into, and talk for a minute about the leader behind the work. This would not have been possible. Not any version of it would have been possible without the leadership and tenacity and the stamina of Dr. Lauren Hughes. We got a gem in Colorado when she came here. And I have worked with her now for over a year, 13 months, and I am just still coming to realize her brilliance in this. So I want to stop and stop just for a moment from talking about the work and talk about the worker here. She's a gold mine for Colorado, and I can't wait to see what comes out next, what she's got cooking next with the Farley Health Policy Center. So kudos to Farley for recruiting her to Colorado. Huge win for our state, huge win for our rural and underserved communities, both urban and rural underserved communities. So thank you, Dr. Hughes, if you're on this call, for everything you did to produce that document, which was released to all 1,100 rural hospitals in the United States, and is being used all over the country for different reasons, is informing the Bipartisan Policy Center right now on some of their policies. So much came out of what Dr. Hughes led in this effort. It's a privilege to be associated with her in this. The next step for this, there are a couple of next steps. One of them is that in the capacity in the playbook is a capacity assessment tool. It's 7 or 8 pages, but it's really it's a template, and it's pretty simple to complete. It's meant to take about 2 hours for a rural hospital to complete. It's equity focused, and it really can give a rural hospital a look in the mirror as far as what they're working with within their own community, what they're capable of doing. And it asks about governance. It asks about leadership. It asks about the financial health of the organization, their emergency preparedness. It takes a look at what they're tracking around quality and clinical care. And so what we're doing is we're partnering initially with the Eastern Plains Healthcare Consortium, several primary care practices, and some public health departments in our state to take a look at their own capacities within their own organizations. In the Eastern Plains, we're actually going to synthesize that data through the association and release a document that can give funders, state government, federal government, other stakeholders in our state a look into what's going on at the rural healthcare delivery level in the Eastern Plains. So synthesize that data and produce one summary, and it's being led by Rachel Smith, the Director of Nursing at Lincoln Health, who's currently in a Master of Public Health program at the Dartmouth Institute for Health Policy. This is her practice. This is her action learning project, applying her knowledge. And so we're going to produce this by August, and we'll release it to anyone who's interested in it. But it should paint a really good picture of what's going on in that part of Colorado. And our hope is that we would be able to scale that across the state and then produce a more collective document, helping our health funders and others at the state really informing decisions that they may make around allocation of resources and strategies. So a common tool that we're advising our healthcare delivery systems to use, and perhaps it would be helpful to you all as well, is we would call it a 6-question tool, but it really starts before the six questions. We ask an initial question, which is, if we took what we're already measuring and we divided it by people group, what would we find? And that can happen in any healthcare delivery system, in any size community, urban or rural. We can all take what we're already measuring, the health outcomes we're already measuring. We can divide them by people group, and we see if there are disparities. So often we hear in rural, for example, oh, we don't have a health disparity issue because we don't have diversity here. I want to pause when I hear that and say, wait. Are we thinking of all the different people groups? Are we thinking about this holistically, or are we only looking at ethnicity? Can we look at other people groups? So we take what we're already measuring, divide that by people group, and then we ask, as we look at the data and we've asked people first, what outcomes matter to you? What are you after when you access the healthcare delivery system? What are you after for your life and for your health? Then we ask collectively, when we look at the bottom of the pyramid, what outcome needs improvement? And then we ask, who are the stakeholders? Who can help? Who cares about this stuff? Where can they share? Where are there opportunities to share? Then why isn't it already happening? What are the barriers? Why isn't it already fixed? Why isn't it already improved? Why does the disparity exist to begin with? Then how do we measure the success? How do we know we made a difference with it? How do we measure it? And then when do we expect to see progress? And out of that, we can come up with a foundation for a strategy. That's how we begin, by working backwards. We ask, what outcome needs improvement? What does it need to look like? So what does the next phase look like? Well, we have partnered with the Caring for Colorado Foundation to launch a 9-case teaching series that will go statewide, and it will be 50 pupils, 50 people in each session. So that will include hospitals, primary care practices, public health folks, and hospitals, including board members and clinicians and administrators. And we're going to bring these folks together to look at 9 mostly true story cases that we've written in partnership with some of the nation's leading academic institutions around healthcare delivery. And we're going to incorporate the content of the playbook and the strategic questions of the playbook as we launch these this summer. So excited about those. And so 2 of them are going to be in partnership with the Harvard Center for Primary Care and a woman named Erin Sullivan at Harvard, who is a master case writer, brilliant person. And so we're writing these together. I'm so excited about them. We're going to publish them through her IRB, but they're intended to be made free. Dr. Hughes and I are co-writing them with Dr. Sullivan at Harvard, and these will be true stories. The first one being on rural equity, and the next one being on physician burnout in a rural context. But they're intended to end incomplete, to bring people to developing their own solutions in their own context using these. But 2 of them are from there. There are a pair from the Value Institute. One is on rural governance. We introduced it a year ago at our rural conference. We're going to bring it out again through a lens of crisis communication. One's on maternal child equity, specifically around women of color, but developing systems around maternal child equity. That case is also written, complete, and ready to go. One is through the Tuck School of Business at Dartmouth, and it was written out of Aspen Valley Hospital in the Rocky Mountain or Western ACO. And value-based care in the shadow of a pandemic. This is one that we'll be rolling out this year as part of this case series. And then a merger, the last one's on a merger of 2 rural hospitals into one system. That's written through the Breach School of Business at Drury University. This one's also ready to go. Very excited to be able to teach this and to involve some of the protagonists in the case in these teachings. So just briefly, when we look at this is the strategic plan summary. And here are all the areas that we've touched in the strategic plan this last year. And we are just now building out a new driver diagram, a new analysis of what we intend to get done here in 2021, in 2022 as well. So that is next, but the vision has not changed. The focus areas of data, workforce, capacity building, access, and collaboration. Those remain the same, just the specific work underneath changes. So in closing, why is this work important to me? First, here are some lessons learned. As leaders, we must each serve as a steady guiding North Star. Our teams must see us as people who are constantly, consistently looking at the map and understanding what's the right thing to do, where's the right place to go. And they got to trust us that we have equity and justice in mind when we make those key decisions. Second, why did it take a crisis to get here? COVID highlighted and exploited the hairline fractures in our system. We can't ignore them anymore. Third, where are the solutions? As leaders, we got to listen to the people on the front line. The people in the rural communities, the people in the urban and marginalized communities, we have to listen to them and ask them, what are you after? What are you struggling with? How can we help you get where you desire to go? Otherwise, we have a mismatch. And lastly, is collaboration required or simply a best practice? People die if we don't. People die in this environment if we don't work together. They die if we don't work together. It's not just a best practice. It's not just a profitability strategy. People die if we don't. We saw it in the Combined Hospital Transfer Center that the Hospital Association put together, where we could guarantee that every Coloradan would get an inpatient bed that needed one, that we wouldn't turn anyone away that needed oxygen, that it needed inpatient care, even in the first and the second peaks of the spread of COVID-19. If we didn't do that, I'm convinced people would have died. And then we have to ask ourselves, if that harm was avoidable, was it morally unacceptable? We must work together to do this stuff. And here's why it's important to me specifically. There are millions of kiddos just like this one in the United States whose lives hang in the rafters hang in the balance of whether or not we can figure this stuff out together. This little boy was particularly well resourced because his dad was a hospital CEO. And still, we came up short. And I'm haunted and I'm inspired at the same time by the people who don't have those resources, who will never know what we did to ensure they have them, but whose lives will be impacted nonetheless. And I'll close with this. A lesson that we've learned, that we've stared straight in the face over this last 13 months. We were facing it even before that, but it became even more acute, is that exhaustion is a silent thief of empathy. We become so tired when our exhaustion is sustained for so long that we are at risk of ceasing to feel the suffering of other people. And that is a dangerous place to be. And I'm confident that there are people that are on this call for whom this is their reality, that you are facing this. And if that happens, I want to tell you, as a person who has also experienced that level of exhaustion and a gnawing feeling in me, knowing that I should feel something now, but have no capacity to feel it, that there is hope on the end of that, and that there was some structural changes in our own worlds, in the environments that we are in, and some individual boundaries that are also set, that we can come out of that, that there's hope on the other end of it. But we must remember that there are systems that lead to this: burnout, harm, death, and there are systems that lead to healing and life, hope. And we need the healing. So let's work together to develop those systems. Thank you. At this point, I think we open up to questions. Frank?
Yeah. Ben, let me start with just a couple of comments. I hope you live forever. It is a real privilege to know you and to be partnered with you, and to wrestle with these problems on the side of the angels, to try to actually make lives better and save lives. This is good and righteous work. And it's a real privilege to have you talking to us today, as you will do again and again and again, and also to have your shoulder to the same wheel we have our shoulder to. This has been a very beautiful hour for me. Thank you so much. I'm going to trust that those of you who have comments, or especially those of you who have questions, and you'd like to ask Ben about this presentation, we'll jump into the chat room, ask those questions, and I'm gonna let either Linda or Robert manage that. I'm gonna go back on mute.
Ben, do you want to non-share your slides, and then you can maybe see more of the folks?
Done.
Oh, here we go. There we go. And I'm absolutely just okay if folks want to just ask their questions.
And if not questions, I would be curious to know what a takeaway is. As I've done talks around the country, I gained so much wisdom in those simple responses. I would really be encouraged, either through chat or on video, just sharing what would you do differently, or what did you learn?
Janet Meredith wanted to express her gratitude and especially for the reminder to begin with the end in mind. And Larry Green, could you comment on what metro areas need to learn from rural areas?
I can take that one. When I was a CEO in Kearney County, and Dr. Elizabeth Teisberg, encouraging me to ask people what mattered to them. She said, so often in healthcare, we ask if the sheets were soft and if the bed was comfortable, if the nurses were nice to you, if the food was warm and delivered on time. Essentially, we're asking about hotel services, or really how are we, or how did we do, when we should be asking a patient once they leave, our care in the healthcare delivery system. How are you? Is your arm better? Or is your blood pressure still high? Does your chest still hurt? Are you taking your meds? Did you get your meds filled? Do you have a ride to the pharmacy? Or do you have the ability to access the drugs? Are you choosing between food and drugs? Because if you are, Maslow says you choose the food, not the drugs. And so are we asking the right questions? And so we did this in a rural community where we engaged our households, and we got an 85% response rate in our rural community. Household response rate with less than 5% duplicate rate when we engage them and ask them how they define their health, and get the demographic stuff, but we ask them how they define their health and what they were aware of in the major sectors of society: healthcare, public health, early childhood development, research and extension, faith, community, employers, the community as a whole, or they were aware of that would help improve their health and what they'd want to see more of. And then we were able to divide that data by people group and see. But we got that response rate because we leveraged the people that Malcolm Gladwell in his tipping point called connectors. They knew everybody. And rural communities are relationship focused. They'll choose relationships sometimes even over logic. Take a look at the vaccine trend going on. The people of influence in a rural community endorse the vaccine. Vaccination rates are much higher. If they're not for it, then they're going to be lower. They will choose relationships even over data or logic. And so the power of relationship is something that I think rural America can teach the rest of us, because that can be harmful, or it can also be leveraged for good. And when we were surveying folks, I mean, we got data that led to millions of dollars in grant interventions simply because we could identify the need with an 85% response rate. And we can do that in urban neighborhoods too, because an urban neighborhood can often function like a small town. And if we figure out who the influencers are in those communities, and we can engage those people, those connector folks, we can really get a good picture of what a neighborhood needs, and we can respond in the same way. So rural does relationships well, and I think we can learn about that in urban.
Jeanette Waxmonsky is asking, are rural hospitals providing any self-care or burnout prevention programs for healthcare providers as a result of COVID-19?
I think yes, they are. I mean, we're hearing about, and we've talked about it on statewide rural calls. We involve Mind Springs Health in providing some resources, even for CEOs who are experiencing advanced stages of burnout. So we're able to talk through some of the individual tools. The harder stuff to address is the systemic stuff, because the reality is mindfulness classes don't fix call schedules. Breathing courses don't fix a dysfunctional EMR. So those are some of the key drivers that can lead people to a point of despair. And so I think there are more and more discussions happening right now. A good resource around this is Amy Gallagher. She's a PhD level psychologist at Mind Springs. She's in that Texas program right now, and her project within the Master of Science in Healthcare Transformation is around the systemic drivers of burnout in a rural context. And so she's a great statewide resource. I would encourage anybody that's curious about that to reach out to Dr. Gallagher, because this is the focus of her research right now. Thanks, Jeanette, for the question. Any others? So Frank, this is my first one of these, and I'm not sure what a normal discussion is, and I'm happy to answer stuff through the chat or have discussions via video chat as well. I just want to make sure that it's a good use of all of your time as we have this discussion.
Ben, I think we're all trying to figure out how we do this well together. But I have two suggestions. One of them is to make sure everybody who's here and everybody who was here knows how to get to you. Mm-hmm. And I want to reassure this audience, this group, that they and we haven't seen the last of you, because this is a conversation. This is not a one-off. We have committed to partnering with you, Ben, in order to develop programs that take advantage of our respective strengths to help make people in rural Colorado healthier. It's our goal. It's what we're living for. And so those of you here who have ideas about that, who wish to put your shoulder to the wheel, who have questions about that. Ben has put his straightforward email address in the chat room. You know how to get to me or Linda Niebauer or Lauren Hughes because you got here. So consider yourself part of the family and consider this an ongoing conversation that will pick up soon.
Sada Hameditz says she would love to know more substantive takeaways from the work in the future. And Lynn Jones, a takeaway for me is can't solve structural problems with individual solutions. And Sada, again, what was surprising, what we can use as family physicians and clinical researchers and leaders. And Deb Seymour, my takeaway as well. And Lori Connolly, excellent and thought-provoking. Clearly the comments are, wow, we are very grateful to have you.
Thank you. I probably take this chance to say, or take this moment to say, I am a shameless, unabashed fan of family medicine. I have seen family medicine in a rural frontier context work at its very best. I mean, I've seen the capacity and the possibility of full scope family medicine and the relationship, its relationship focus that is such a good fit. And I'm convinced it also works well or can work well in urban spaces, but such a good fit in rural and frontier areas. I've seen on the same day a doctor save the life of a patient in the emergency department that was experiencing an acute MI, deliver a baby by C-section, round on patients in a hospital, perform a vasectomy, remove a toenail, deal with a patient in a behavioral health crisis on the same day. I mean, I remember that day, and that day wasn't all that unique. I've seen that happen, and I've seen them do it well, and I've seen them have outcomes that can back up what they're doing. And I think about the behavioral health crisis we're in right now and how important it is to back up family medicine with the specialty resources that are needed to ensure that they can practice at the highest level or at the max of their license. So it's a privilege to be affiliated with. I mean, I got a volunteer faculty appointment with CU Family Medicine. And I felt like such a nerd and I was like a groupie, like I'm a fan, and I get to be formally associated with you all. So there's my plug for family medicine.
Let me read what Deanna Schroeder has here. She says, thank you for this presentation. I wish I had a question. I'm just trying to absorb it all. I think we do need to hear this kind of information over and over. Thanks for making this a conversation, not just an event. Takeaway for me is that there are needs on both sides, providers and patients, that can be served by some of the same systemic changes. The real life awareness you have of where the difficulties come from and the belief you shared that change is possible is also valuable.
Well, I would love to have coffee with you. That sounds like a fun conversation to have next. That's great.
Well, gosh, thank you so much. Can't thank you enough for making the time.
It's a privilege.
Thank you, Ben. To be continued. And with that, we'll end our Levitt lecture.